Good morning. My name is Gary Joffe, and I'd like to thank Dr. Rebecca Vasilian for asking me to come and speak about Zika virus in pregnancy today. A couple of little housekeeping details. I have a partner by the name of Dr. Kent Argubright. He is a very, very smart man, as you all know. He's smart enough that every time his turn comes up to give a talk, I end up doing it. So would you please, when you see him, let him know. Other housekeeping details. I have no financial association with the companies that I mentioned today. And finally, some of you know that I have been battling my own respiratory virus for the past 3 weeks. And so if my voice suddenly sounds like it's breaking into puberty, I apologize. Zika virus and pregnancy. Our objectives today are, number one, to discuss the epidemiology of the current Zika crisis, define the characteristics of the Aedes mosquito species. We will attempt to discuss the virology of the Zika virus. We will define the clinical characteristics of adult Zika infection. We will mention in utero transmission and clinical findings associated with both fetal and neonatal infection. We will outline recommendations for Zika prevention. I will try to define the recommended testing for suspected Zika virus infection in pregnancy, and we will update the status of vaccination for Zika prevention. Starting with epidemiology, Zika virus was actually first reported in Uganda in 1947 in a monkey. And this kind of surprised me because if you remember back to your biology days, Watson and Crick really didn't come forward with their whole DNA research and Nobel Prize until the early to mid 50s. And yet some form of virology research and recognition was going on in the late 40s and 50s. Dengue, for instance, was very well characterized as some sort of zoonotic infection at that time. In May of 2015, the World Health Organization confirmed the first local mosquito to human transmission of Zika virus in the Americas in Brazil. By the end of 2015, in Brazil, there were reportedly between 440,000 and 1.3 million cases of Zika virus disease had occurred. I should mention to you that all of my talk today can be found on the website cdc.gov. This is where I took 90% of this from. I also referenced Patrick Duff, who is a leading OBGYN infectious disease researcher. And then I've referenced some articles from the New England Journal, and you'll see those in here as well. The epicenter, if you will, for Zika in Brazil is in the Pernambuco region in northeastern Brazil. That's a state in Brazil. The major city that has been impacted is the city of Recife. Pernambuco, I learned, has a population of about 9 to 10 million people, with the city of Recife having about 3.5 to 4 million people. Huge place. This is a major economic center for Brazil. This area was settled by the Dutch in the late 1500s, and then the Portuguese moved in after that. This area is an epicenter or a hub for the export of sugarcane and oil, and both a 2016 World Cup event as well as Olympic events occurred there as well. So there's a little picture of Pernambuco State out on the northeast edge of Brazil. My little arrow right there. Very beautiful city as I kind of looked through it and tried to learn about the place. Gorgeous beaches, high rises, very well-off population, obviously. Some of the, I think the Condé Nast traveler describes this beach outside of Recife as being the most beautiful beach in the world. But here's the opposite side of the hill. And this, of course, is a favela. And you can kind of see the beautiful buildings in the background, and yet look at the crowding and poverty just at the doorstep there. And you can see here where a favela is up against basically a cesspool, perfect breeding ground for mosquitoes. Crowding, disease, mosquitoes all can lead towards the possibility of rapid spread of disease and epidemic. This is a picture from the rehabilitation clinic in Recife, and I don't know that you can read that on the bottom, but this is Moises and Myrna Albuquerque. That's their name, which I thought was kind of ironic. This was taken from Time magazine in February of 2016, and they're bringing their little son to the rehabilitation clinic. And that clinic has been set up by a family of physicians by the name of Van Holland. And the Van Hollands were actually the physicians who put two and two together regarding the alarming increase in the incidence of neonatal microcephaly and the spread of a rash-like disease, which of course was Zika. And it's kind of a fascinating read to see how they push their way through the health system to try to get recognition for this. That's actually one of the Van Hollands measuring a little baby's cranium. That's her up in the picture there with one of her, either her daughter or one of her patients. And she's actually showing you an MRI of a neonate with severe intracranial anomalies. And even at this distance, and we'll look at these in some more detail, but even at this distance, you can see the ventriculomegaly within the posterior horns here. And she is, just lost my arrow. She is, oh, sorry. She is pointing out some cortical atrophy there. Here's a mom with her 7-month-old with microcephaly. The state of Pernambuco and the city of Recife are trying to respond to this crisis. And I found this picture to be both kind of fascinating and instructional as well. What you're seeing are members of the military out in a neighborhood here, and they are canvassing this neighborhood, and what they're looking for are any areas of standing water, basically. Cups, puddles, pools, garbage, and they're going to point out where this area needs to be sprayed, and they're trying to educate the citizens there of preventative measures, which are, in a sense, relatively simple, perhaps for us, to get rid of standing water around your home, ponding. But the other thing that I found interesting was whenever I'm counseling a patient regarding mosquito bite prevention, look at the soldiers. They're all wearing complete covering. They're wearing a hat, and you can guarantee that their clothes are pre-treated with permethrin, which a lot of camping and outdoor gear is to try to prevent mosquito bites. Look at the little girls in the foreground there. They're happy playing, uncovered, but you got the soldiers well protected there. So I thought that was just kind of a interesting little picture. The mosquito that is responsible for transmission of the Zika virus are the Aedes species, the Aegypti and the albopictus. They also transmit dengue, chikungunya, and yellow fever. Part of the problem with crises in all of these areas of the Far East and the South Pacific and South America, and perhaps what delayed some of the recognition that this was a different virus, is that all of these viruses can give clinical characteristics that are very similar. They all fall into the category of RNA flaviviruses. Dengue, for instance, can look very, very similar to Zika in its presentation. Mild fever, coryza, rash, myalgia, 3 to 5 day incubation period, 7 to 14 day duration, and in most people it's gone. And many people, 30 to 40%, who have dengue or chikungunya or Zika don't even recognize that they had the disease. And so perhaps that's where part of the delay came. Dengue is different than Zika in the sense that it oftentimes hits children much more acutely and severely than adults. And dengue is characterized by spontaneous bleeding, epistaxis, bruising, and the severe complications with dengue can include anemia and thrombocytopenia. And so that's where the classic hemorrhagic fever comes from. Chikungunya, and I just love to say chikungunya, I don't know why, but chikungunya affects the immune system a little differently than dengue or Zika, even though they're very closely related. Chikungunya is associated with a much higher fever. When I read about this, they described the arthralgia as being a broken bone type of feeling. It's quite severe. A little longer lasting, no hemorrhage, but the portion of the immune system that is affected by chikungunya can lead to much more long-term complications in terms of severe joint and permanent joint abnormalities. The significant swelling that you'll see in a person's joints may result in lifelong arthritis and disability. And yet, the initial presentation of these things can appear very, very similar. Current evidence suggests that the origin of the current outbreak came from viral strains in French Polynesia around 2013 to 2014. There were 28,000 cases. Now, how many of you knew about the outbreak of Zika in French Polynesia in 2013? Go ahead and raise your hands. Right. None of us know about these things, but boy, are we going to know about them now. Did you ever read the book, The World is Hot, Flat, and Crowded? Really interesting, kind of a fascinating manuscript on how we've arrived at having diseases on our doorstep now, things that we just never thought about unless you were with, Doctors Without Borders and went out and saw the real world. But I'm kind of emphasizing these because within the next 3, 5, 10 years, those of us who are still alive and practicing are going to actually see these diseases frequently because the world is so hot, flat, and crowded. I'm very geographically challenged, and I didn't realize that French Polynesia equals Tahiti. Nikki knows, but I had no idea. So I said, oh, French Polynesia, Tahiti. One of the interesting things about the outbreak in Tahiti and those islands, number one, they first thought it was dengue, and secondly, the wave came and then it completely passed. There is no Zika or ongoing Zika to speak of in French Polynesia right now. And that's curious and exciting and makes one wonder, well, why is that? Did they go in there and spray Tahiti? Unlikely, but perhaps the immune systems of people in French Polynesia, which may have been primed with things like dengue and chikungunya, have been able to, in a sense, eliminate the spread of infection of this disease. Just throwing these things out there. But there are 28,000, and now there's no Zika to speak of in French Polynesia. How about moving north a little bit? This is from Nature magazine in May or June of this year, and you see how Zika has moved up into Central America, Cuba, the Bahamas, Jamaica. Look at Honduras. Look at Cuba. Cuba, three cases as of June. To me, that's kind of fascinating, and there's a reason for it, and that is because of dengue. Back in the early 80s, Cuba was decimated by dengue, 900,000 to 1 million cases. And Cuba, being the type of government that they have, went in and said, never again, and we are going to spray until every last mosquito is gone. And they kept spraying and spraying and spraying, and they eliminated essentially dengue from Cuba. And the article was pointed out the fact that with the fall of the Soviet Union in the late 80s, when the funding from the Soviet Union suddenly went away in the early 90s, all of a sudden the incidence of dengue went back up in Cuba. And so clearly they're spraying, and the heavy fines that they lay on their citizens for having conditions that foster mosquitoes have essentially eliminated a major disease, and that is probably part of the reason that Cuba seems to not have much of an incidence of Zika at all. Now, of course, Cuba, it's going to be fascinating to see what happens with Cuba now that Cuba is opening up to the world, and how are they going to deal with this. The law of unintended consequences. I pulled this article just recently off of a page from CNN. Bee apocalypse. What lessons did we learn from Zika spraying? Well, in South Carolina, they identified, near Charleston, they identified a little pocket of the Aedes mosquito, the Aedes aegypti. And the health department and the authorities there said, quite rightly, get rid of it. The problem was the woman identified in this article said, I'm a beekeeper, and you just wiped out 3 million of my honeybees, and this is like cracking a walnut with a sledgehammer. Why did you do this? And so all of these spraying and the things that we do on the one hand can have effects elsewhere. The health department said, wherever we see Aedes, we're going to get rid of it. You, the beekeepers, need to register with us because we know the time of day to spray. Bees apparently go into their hives in the evening and come out in the morning. And they said if they know where you're keeping your beehives, they will spray at the appropriate times and try to stay away from there. But they pointed out in the article that beekeepers are very secretive people, and they don't like to share that type of information. And so maybe this is, again, the law of unintended consequences. I didn't have any peaches, cherries, quince, or anything this year in my neighborhood where they spray very heavily for mosquitoes, just as an aside. There's the culprit, Aedes aegypti, and this mosquito can be really distinguished from our Culex mosquitoes, and we have 2 Culex species here. Aedes are very distinct in their black and white checkerboard pattern that you can kind of see right up here. There's a mosquito expert and the head of mosquito spraying here in Bernalillo County. His name is Paul Smith, and he says that if you actually happen to pull one of these off of your forearm, save it and call Bernalillo County and show it to them so that they can document that it's here. I have his number if you need it. Here's a electron microscope and stained representation of the Zika virus. Like all of the flaviviruses, these are all single-stranded RNA viruses. They're enveloped or enveloped, however you like to say that, as opposed to naked viruses. And the Zika virus has the characteristic starfish appearance. I'm just joking, but I like the pictures of the little starfish on there. Here's Zika virus racing past some red blood cells who don't give a hoot. And here's another picture of a Zika virus showing you the little coat proteins that attach to our cells. In terms of symptoms, we've already kind of touched on them. Usually a self-limiting infection, incubation period generally 3 to 5 days, duration 10 to 14 days, characterized by coryza, diarrhea, headache, joint pain, pale skin, and perhaps a little macular rash and a moderate fever. Zika can be transmitted in a number of ways. Of course, the bite of an infected mosquito, through blood transfusion, sexual transmission, maternal to fetal transmission. Of course, that's the reason I'm here. Zika RNA has been isolated from breast milk. Nobody, as of this week, has documented transmission to a neonate. Theoretically, organ or tissue transplantation. The CDC says that in terms of transfusion and blood donation, most affected persons are asymptomatic, so they don't know that they are carriers. Zika transmission has been demonstrated through blood products in Brazil and French Polynesia, and in French Polynesia, 2.8% of donors tested positive. On August 26th, the FDA called for blood collection centers in U.S. to screen all donated blood for Zika. That's a mandate, a requirement now. They state that a questionnaire is insufficient. Now, The CDC says that there are no currently FDA licensed tests available, but 2 separate investigational new drug tests became available on April 3rd of 2016, one by Roche, the other by Hologic, made by Hologic. And currently, Puerto Rico, Texas, Florida, Alabama, Mississippi, Georgia, and South Carolina are testing all blood, with everybody else trying to come online. Basically the SEC there. How about the virology? I want to take a couple of minutes with this. It's fascinating to me that a piece of RNA that is 10 genes long, right here, oops, where did I go? Thank you. 10 genes long here, which is broken up into structural and functional components, can cause such havoc. And it's also fascinating that variations in 10 genes between viruses that cause chikungunya, Zika, yellow fever, can cause such markedly different clinical manifestations. That's amazing to me. And the other thing to remember, of course, is that, golly, the thing to remember is how they do this thing. The other thing to remember is that the concept of viral shift. And viruses mutate constantly. And we've learned this over the past few years, which with H1N1, H3N2, influenza A, influenza B. This is the reason that when the CDC is coming up with a vaccine for the following year, they're guessing as to what mutation is going to occur, and why perhaps only 65 to 75% of people who receive a flu shot are actually immunized. Viruses shift, and I think it isn't a stretch to say that what has happened in Brazil is likely, at least partially, the result of viral shift. When you had a population that should have been so immunologically ready to deal with something like Zika, and yet it's run rampant and caused such severe disease. When, I swear I'm just hitting the middle of this thing. I guess I'm pressing too hard. When a virus, I don't like being without a pointer. So look at the big circle there. That's representative of a lymphocyte. When the virus has somehow been deposited in your skin, your lymphocytes quickly recognize it, and they actually shake hands with it and say, come on in, I've got receptors on my surface, come on in here and I'm going to take care of you. When the virus goes in, it's picked up by something called an endosome. And typically when our lymphocytes pick up foreign pathogens, help me?
Endosome.
Thank you, endosomes tend to take these things to the right place and destroy them. However, where you see in red there, the machinery of the virus gets around that, and suddenly the RNA of the virus is sitting free out in the cellular matrix. If you look in the middle, you see the nucleus, and surrounding the nucleus is the endoplasmic reticulum. The nucleus, our nucleus of course, has DNA, which is translated into messenger RNA, and that messenger RNA ends up out in the endoplasmic reticulum. You see that little snake-like RNA of Zika virus sitting out there in the cytoplasm, well, it makes its way into the endoplasmic reticulum. And if you look at the bottom, you can see then where the viral RNA takes over and lines itself up, if you will, with our messenger RNA and starts taking over the machinery of our cells. And you can see the arrow going off to the right. The structural proteins and the enzymes are being put together in that representation on the right. On the left, though, is more and rapid replication of the viral RNA. So let's make more, let's make more, let's make more. Eventually, the virus leaves the cell, and the virus kind of decides, when I leave, am I going to blow you up, or am I just going to leave and let more virus come in? That's kind of virus and disease specific. And of course, this happens incredibly fast, and we start to feel symptoms. You know, you're looking at 3 to 5 days here of viral replication before our immune system starts to get sick. The other thing that's kind of fascinating to think about is that depending on the virus will pick up a particular type of immune mediator. For example, Dengue is picked up by lymphocytes that are then programmed to make heparin-like compounds, which then start our vasculature to vasodilate, of course to our detriment, but it's perfect for the virus because it puts more virus out in the tissue. Chikungunya, different immune mediator. In our own area here with Culex, West Nile, different immune mediators going to the neurosystem. So just incredibly complex and ever-changing. So let's get away from basic science just a little bit. There were kind of two sets of recommendations that came out from the CDC regarding Zika, both in terms of prevention and testing. The first came out on January 15th of 2016, and at that time, pregnant women were advised to consider postponing travel to areas with ongoing Zika virus transmission. For those residing in areas of ongoing transmission, healthcare providers should discuss pregnancy intention and reproductive options, and you can read between the lines there. Initial epidemiologic evidence suggested a link between a maternal rash-like illness and microcephaly suggestive of Zika infection. Kind of starting to fulfill Koch's and Shepard's postulates of proof of disease transmission. Amniotic fluid obtained from 2 children with microcephaly tested that should be positive for Zika virus RNA. No matter how you read these slides, you always miss one error. Laboratory testing from tissue of 3 neonates and 2 fetal losses with microcephaly also found Zika. They updated their recommendations for testing and prevention again in April of this year to state that this is a nationally notifiable condition. Now the CDC just simply doesn't suggest, they recommend pregnant women not travel to an area with active virus transmission. If a pregnant woman must travel to one of these areas, she should talk to her healthcare provider. If she travels, she should be counseled to strictly follow the steps to avoid mosquito bites and prevent sexual transmission during the trip. If a pregnant woman has a partner who lives in or has traveled to an area with Zika, she should use condoms or other barrier protection every time she has sex, or should not have sex with that partner for the duration of her pregnancy. We're going to get into the testing, how to test for Zika section of this, and this is kind of a hot mess when you read this from the CDC. And the way I've tried to think about this is just to simplify it a little bit. When you're thinking about, and by the way, there's a golden nugget that's the answer for everything at the end of this. When you're thinking about a woman who may have had exposure, you want to think in terms of, did she travel to that area or does she reside there? Was she symptomatic or asymptomatic? If she's symptomatic, are you seeing her within the first 2 weeks of her infection or between weeks 2 and 12? Okay, so that's kind of a general framework to think about. Endemic or traveler, symptomatic or not symptomatic, 0 to 2 weeks or 2 to 12 weeks. And then the other things to think about are the types of testing, which are either reverse transcriptase testing by PCR from urine and blood, or IgM. So those are our kind of our who we're treating and our tools. Now this is straight from the CDC. For symptomatic pregnant women with exposure to Zika virus, reverse transcriptase PCR testing of serum and urine is recommended up to 2 weeks after symptom onset. Then they jump to back to asymptomatic women. For asymptomatic pregnant women who live in areas without active Zika virus transmission, but who, without active Zika virus transmission, reverse transcriptase PCR testing of serum and urine is recommended less than 2 weeks after the last possible exposure. So this is the patient that we are most likely to see. They live here, they've traveled to Puerto Rico or wherever that has Zika. They come back and they tell you, I traveled there. And they tell you, you ask them, and we'll go through the sheet here in a minute, you ask them whether they were symptomatic or not, and when did they travel. If they've traveled if they present to you within 2 weeks of travel, then you do PCR testing. For those same patients exposed between 2 and 12 weeks, Zika virus IgM should be obtained. And the problem here is that our immune systems clear the virus and the viral RNA rather quickly. And so if you see a patient at week 3 or 4 after she travels and you get PCR, that RNA may be gone. And so you don't really know whether she had the disease or not. But by that time, your immunoglobulin M has kicked in, and you can isolate that from the blood. For women who are evaluated 2 to 12 weeks after exposure and have been found to be Zika virus IgM positive, then you go back to reverse transcriptase PCR testing of serum and urine, because by that time the virus will have kicked back in and that test is likely to be positive. Told you this was a hot mess. Asymptomatic pregnant women with exposure to Zika may be offered screening with serologic testing, that's IgM, within 2 to 12 weeks after the last date of possible exposure. Now, for patients like Mrs. Albuquerque, who we saw before, who live in areas of ongoing infection, asymptomatic women who live in areas with active Zika virus transmission should have Zika virus IgM testing as part of routine obstetric care during the first and second trimesters, with immediate PCR testing of women who are IgM positive. Fortunately, That's only people in Florida, in the Miami area right now for us, but of course this is going to change. A positive PCR test provides a definitive diagnosis of Zika virus infection, but not transmission to the fetus. Local health officials should determine when to implement testing of asymptomatic pregnant women on the basis of information about the levels of Zika virus transmission and laboratory capacity. Now, more specifically, and I tried to hone this down a little bit, what they did between the first recommendation and the second was they extended the PCR testing to 2 weeks of exposure. They added a new recommendation to implement Zika-specific PCR testing of serum and urine among asymptomatic pregnant women with possible exposure. They added a new recommendation for immediate PCR testing after a pregnant woman has a positive or equivocal Zika IgM antibody test. And they updated the guidelines to emphasize testing of infant blood rather than infant blood or cord blood. So to summarize, whether the person was symptomatic or asymptomatic, if they present to you less than 2 weeks after either exposure or symptoms, both serum and urine should be tested by Zika virus real-time reverse transcriptase polymerase chain reaction. 2 to 12 weeks after symptom onset, serum that has been collected from patients presenting 2 to 12 weeks from onset of symptoms should be tested first by IgM detection methods. Serum from symptomatic pregnant women should also be accompanied by a urine specimen. For symptomatic pregnant women, anti-Zika IgM positive or equivocal results followed by a negative PCR on both serum and urine should have something called a plaque-reducing neutralization test. And this is a way that laboratory personnel can now take the IgM antibody and determine whether that IgM antibody has been floating around for a long time perhaps in response to things like dengue or chikungunya, and they can see if it's more specific to Zika. And what they do is coat a plate, an agar plate with Zika virus, and they will subsequently take mom's serum and they will take that serum, coat it on the virus, and see how many plaques of virus are eliminated. And then they'll dilute that same specimen in half, and then again they'll see how many plaques of virus are eliminated, and based on that, kind of the LD50 concept, they can determine whether that antibody is real and likely represents infection, or whether it's a false positive. Laboratory testing. But there is a golden nugget in all of this, and I'll give it to you in a minute. Finally, if serum and urine have been collected from a pregnant woman presenting within 2 weeks of her exposure, serum and urine should be tested by PCR. If negative, a second serum specimen should be collected 2 to 12 weeks following return from travel and tested by antibody detection methods. So anymore, it isn't okay just to get one set of IgM. You need to repeat it again later in pregnancy. The golden nugget. Call the New Mexico Department of Health. This is what we do. Anytime a patient comes, we don't go into all of the IgMs and PCRs and when were you exposed and et cetera, et cetera. We call the New Mexico Department of Health. That's their hotline. They are wonderful. And they work directly with the CDC. All requests must come from a medical provider. That's the fail-safe right there. I want to segue, that kind of is my segue into New Mexico specifically. We have IEDs in New Mexico. Been here for a long time. Hopefully, currently not infected with Zika. Seems to be isolated in the southern part of the state. That's the congressional district of Congressman Steve Pierce. And I mentioned his name because in January or February, President Obama actually put legislation to the Senate and to the House requesting $1.3 billion for Zika research. Your Congressman Udall and Heinrich have voted Martin Heinrich have voted for this legislation. Congressman Pierce has not. Typical Congress, and yet it's his district right down there, Pierce's district, that right now is at the most risk for Zika transmission. So, write your congressman. Pregnancy. Infection can occur in any trimester. Symptoms are similar to non-pregnant individuals, and they don't seem to be, the mom doesn't seem to be more susceptible or severely affected. I should mention Guillain-Barré. I haven't mentioned it yet. One of the side effects of all of the flaviviruses, if a person happens to be unlucky, is to get Guillain-Barré, which is a peripheral demyelinating disease which can result in paresthesias, numbness, that seems to ascend in some people and can affect the respiratory system, the respiratory muscles, and in about 1 in 70,000 individuals can lead to need for ventilation. And so at some point, I'm sure we will read about a mom who has Guillain-Barré because of Zika, but I need to mention that. Again, coryza, diarrhea, headache, arthralgia, rash, and fever. Maternal to fetal infection is demonstrated in each trimester. Very well documented now are microcephaly, brain atrophy, ventriculomegaly, intracranial calcifications, and cerebellar agenesis. From New England Journal, exposure in the late first and early second trimester poses the greatest risk for CNS injury. Again from New England Journal, current estimates of microcephaly with first trimester exposure range between 1 to 13%. The ultrasound that you see on the right is normal cranial anatomy, and if you look in the middle, I'm afraid to do this. If you look in the middle, you see the normal thalami and very thin third ventricle. To the left of that is the cavum septum pellucidum. Down below and a little bit kind of southwest of the thalami is the cerebral atria, that snowball that you see there. That's the way that that's supposed to look. If you look at the ultrasound on the left, right in the middle, you'll see a dilated third ventricle. If you move to the left of that, you'll see dilated anterior horns of the ventricles. And then if you look at the choroid, or that snowball appearance, you can see that drooping there. And so there's some ultrasound findings from a fetus who had Zika. MRI pictures of a neonate, normal on the right, and up at the top you can see the measurements of the normal cortical thickness. You see how in the center the ventricles are fairly thin. You look on the left and you see that calipers up there in the front, very thin cortex and very dilated anterior and posterior horns of the ventricles. Here's a kind of a sad representation of baby with typical head size, moderate microcephaly, and severe microcephaly. When we're doing ultrasound, we generally consider microcephaly to be severe if our head circumference measurement is greater than 3 standard deviations below the mean. Here's a nice mom and baby from Recife, and you can obviously see the microcephaly that this child has. The problem that Zika also confers, however, is that you don't have to have microcephaly in order to have severe problems. And as these infected but non-microcephalic neonates are now being followed along as they grow, they're looking like rubella type infections. Deafness, severe ocular abnormalities. I've listed, I'm not an ophthalmologist, but I've listed macular atrophy, coloboma, hypoplasia. And when you look in the eye of one of these individuals, you can kind of look over to the right. You see the red reflex, if you will, to the left where the optic nerve is coming in. To the right, kind of looks like a meteor hit it. That's not supposed to be there. You can see all the inflammation around it. So retinas are severely affected by this nasty virus. Unknowns, again from New England Journal. Frequency of maternal fetal transmission, the absolute risk of development for microcephaly, the correlation between the severity of symptoms and fetal and neonatal outcome, and how much of a viral load, maternal immune response, and other factors are necessary for severe infection. We've talked about it already, but all pregnant women should consider postponing travel to areas of ongoing Zika virus transmission. Those who travel should strictly follow steps to avoid mosquito bites, particularly during the daytime. This is my counseling. I just lift this from the CDC. Long clothing, EPA registered insect repellents, deep woods off. That contains a great concentration of DEET. DEET is you have her spray her clothes. I tell all my patients, if you're going up to the Hamas, you're going, to a backyard barbecue, wear light long clothing, socks, a hat, spray your clothes with DEET. Again, we have the Culex mosquitoes. They carry West Nile. I have had a family member who has had West Nile. That is no fun. That is a bad disease. Which takes me to, can our Culex mosquitoes carry Zika? There's mixed literature about that. The scientists at the Washington Post think so. And yet the scientists at the University of Kansas have tried like crazy to infect Culex mosquitoes with Zika and have been unable to do so. And so I think the jury is still out regarding our Culex and whether eventually they could pick up something like Zika. Wear permethrin treated clothing and gear, sleep in screened-in or air-conditioned rooms. Repellents containing DEET, picaridin, IR 3535, eucalyptus with lemon I've seen as a potential mosquito repellent, should be considered to be safe for pregnant and nursing women. Abstain from sex or use condoms if a partner resides in or travels in an area of ongoing Zika virus transmission. And there are about 15 of you out there right now thinking, well, how long can a male stay infected? Currently, the CDC says that if a couple is considering pregnancy, but the partner was infected, wait 6 months. That's what CDC says currently. But these things change all the time, so you have to keep reading the recommendations. We should question all pregnant women regarding recent travel. All positive responders should be evaluated for Zika virus per our guidelines. And those with suspected infection should also be tested for dengue and chikungunya. I put in your packet this morning our Zika virus information and questionnaire form and consent form. I put this together probably in about April of this year, mostly for me, because I was never, ever in the habit of asking patients about their travel. And a patient would come and we'd have a long conversation, and then she would leave and I'd think, oh shoot, I forgot to ask about Zika. So we give this questionnaire to every single patient. We make them read it, and you guys are welcome to this. I'll let you guys read it through. They sign it, and they are signing something that says, I was adequately informed of the risks of travel to areas affected by Zika virus. And this forces me as a provider to counsel everybody. And that's where our role as primary care physicians comes in disease prevention. So anyway, that should be in your handout. Amniotic fluid can be tested for viral RNA by PCR. The sensitivity and specificity is unknown. And of course, fetal and placental tissue is tested by PCR. Treatment of an acute infection is supportive, rest, fluids, analgesics, antipyretics. You want to avoid nonsteroidals because they may have dengue. And we talked about dengue and hemorrhagic fever, and we certainly don't want to contribute to a bleeding diathesis. If you've got confirmed maternal infection by PCR, you can offer amniocentesis after 15 weeks for confirmation of maternal to fetal transmission. And right now, all we can do is serial ultrasound to monitor fetal anatomy and growth every 3 weeks. In the remaining minute, I'll try to run through some good news. This came out of Science in August from Harvard. Protective efficacy of multiple vaccine platforms against a Zika virus challenge in rhesus monkeys. They took 16 rhesus monkeys and they gave 8 of them purified inactivated Zika, or they exposed 8 of them to purified inactive Zika, and they gave 8 a sham. The infected monkeys all developed neutralizing antibodies 2 weeks following immunization. The sham monkeys did not. They then gave them a booster, and the infected monkeys' antibody titers increased. Of course, the sham did not. Binding antibodies followed similar pattern, and the majority of the infected monkeys also developed a modest cellular immune response, not just antibodies, but increases in various types of lymphocytes that respond to the envelope protein. Then they took the immunized and sham monkeys and they gave them 1 million Zika viruses. The sham monkeys got sick 6 to 7 days after injection. They found virus in their urine, CSF, colorectal secretions, cervical vaginal secretions. They could not isolate them from sperm and semen because they couldn't get enough of a sample. True. Think about that. In contrast, the vaccinated monkeys showed complete protection against the Zika challenge. And so those monkeys who had antibodies, who then got challenged with Zika, no problem. There was no detectable virus in any of these secretions. They also took IgG from these monkeys and injected that IgG into other monkeys who were then challenged with virus. And even IgG taken from the immunized monkeys protected the naive monkeys. Purified IgG from Zika vaccinated rhesus monkeys provided passive protection. Rhesus monkeys infected by Zika Brazil following vaccination with both a gene-based or viral transmitted vector provided complete protection against subcutaneous challenge. Fabulous. And so they concluded that adoptive transfer studies demonstrate that vaccine-elicited antibodies are sufficient for protection against Zika virus challenge. Passive protection was observed at relatively low antibody titers. Such antibody titers are likely achievable by these vaccine platforms in humans, raising optimism for the development of a Zika virus vaccine for humans. But there's always the law of unintended consequences. And when you're thinking about perhaps people in the United States, that vaccine challenge may be great. But when you're thinking about the rest of the world who's already been exposed to things like dengue, secondary infection with heterologous dengue serotype can be clinically more severe than initial infection, which may or may not reflect antibody-dependent enhancement. And so perhaps people who have already had dengue who are challenged with this vaccination, their dengue may be much worse the next time that they get it. And there are 4 different serotypes of dengue, and so people can get hit with dengue repetitively. So also, they threw this in here, dengue-specific antibodies have been reported to increase Zika virus replication in vitro. And so there is a phase 1 clinical trial with Zika virus purified immune virus vaccine, as well as other candidate vaccines are expected to begin later this year. So, in summary, this is a true global epidemic. A relatively mild infection for most may result in tragic consequences for the pregnant patient and her newborn. Simple preventative strategies may reduce the likelihood for infection. We need to question all pregnant patients regarding potential exposure, and we need to counsel those who are planning or who are already pregnant. The end. And I'm sure that we don't have time for questions. Questions? Anybody? Yes, Betty.
So, you talked a little bit about mutations in the virus.
Yes.
How likely is the Zika to be one of those like the flu virus that mutates easily?
Highly likely.
So the vaccine may not be that.
Correct. And so it's always the chase. You're always trying, the scientists are always trying to keep up with the mutations. I had no idea until recently, maybe last year, that the way that our flu vaccines are formulated is based on what pattern of flu is going on in the southern hemisphere in the winter time before our winter time. And so it's imperfect by many stretches. Rebecca.
Sorry, it's probably a very large topic, but as far as, do you know the percentages as far as if someone's testing positive that their fetus might not have it, microcephaly or any other?
Well, I think they kind of said 1 to 13%. That's what I see there.
And then you're just leaving it up to them if it's maybe too early to diagnose any microcephaly or other problems if they want to terminate.
That's exactly right. But part of my new counseling, of course, going through this is that you don't have to have microcephaly to have severe consequences. So, you know, more to come. Jim.
Gary, so I've had a number of patients that are actually scheduled to do in vitro fertilization, and they have a date-specific cycle, but they're traveling. They have a destination wedding in the Caribbean. You know, they're going to be a bridesmaid, and they have this obligation. Is there a screening process, or you just say, no, you can't go to the wedding, or you postpone your whole attempt?
Yeah.
Just on the outside chance you
There's no screening process before they go, and yes to the others. I mean, yes. Postpone or don't go, or if you are going to go, sleep in screened in or air-conditioned areas, wear long clothing, wear a hat, wear socks. You know, at the wedding there, spray everybody with DEET. Then you come back and you get tested.
Don't you get the questions of, I got a mosquito bite, what do I do?
Right, and I get that question every day, and here's what I say, and I say, you should frequently access the website cdc.gov. It is a fabulous website, not only for that, but for your immunization schedule, and if you click, there's maps, you click on maps, and I tell them you can hover over anywhere you want to go in the world, and you can see on that day whether the mosquito is there, whether the virus is there, whether the virus has been transmitted from mosquito to person or from person to person.
Do you foresee a time when you can do a screening test prior to the IVF cycle to find out if, I mean,
absolutely.
The mosquitoes,
absolutely. You know, if you practiced in Honduras right now and patients were coming to you, you could do their serum IgM and IgG, and Zika-specific IgG, you're going to find that to be positive in almost the entire population. If you find a patient who is IgM negative, then you've got to be cautious with her. If you find a patient who's IgG negative but IgM positive, then you're going to test her by PCR. That's how you would approach it now. So.
But currently, Gary, all those labs are going through that Department of Health.
Correct. Tushar.
So what type of challenges do you think, or are happening now or could happen as far as decision making for these families? I mean, just a kind of quick rundown. I mean, it's
sure.
That, you know, termination and then continuing with pregnancies, dealing with the aftermath,
right?
Like that. It seems like a real problem potentially.
Refer to the maternal fetal medicine specialist for documented exposure. Thank you, Tushar. Completely challenging. No different than the primary herpes infection in pregnancy, which we've dealt with. These things are rare. We deal with it, of course, with the most commonly transmitted virus, which is CMV. And we have a number of CMV patients every year. And these are the questions that we have to ask them and the counseling that we have to do. And we have experts in our practice, our genetic counselors particularly, who are so well versed on both fetal and neonatal effects, and we try to supplement that as well. And then it comes down to patient decision making.
What I found really striking was the, I don't know if that was a CT or an MRI of the cerebral cortex being as thin as it is.
It's nasty.
And my assumption is that if you wanted to look for that during pregnancy, it would probably be late, second, maybe early third trimester. I don't know if ultrasound picks that up well, or if fetal MRI type would be better.
Right.
But anyway, let's say you're at 28 weeks,
Right.
and you do a fetal MRI and you find a cortex that's super thin, and you
Mhm.
present that to the family,
Mhm.
and does that now open up ethical considerations, ethics,
Sure, absolutely.
consultation?
Yeah. I mean, any anomaly that can consider to be lethal or severe after 23 weeks gestation automatically goes to an ethics committee, the ethics committee here, in order to determine, particularly if a patient is requesting pregnancy termination. Yeah, completely challenging.
Last week I had a really interesting case that kind of mapped all this out for me. I had a woman who traveled up from, she had been in Juarez and her car broke down in
Mhm.
the flood.
Uh-huh.
And she got completely munched on by mosquitoes in the flood.
Uh-huh.
And she was 5 weeks pregnant. It had happened in the last 2 weeks.
Mhm.
And she had obviously read the website. So
Right.
I went on the website, I looked it up, I realized she probably needs the PCR testing. Figured out what needed to be done, called Dr. Eisenberg just to confirm. He was like, yeah, you need to do that. And I went to order it in Tricor.
Uh-huh.
It's not on our EMR.
Right.
And Tricor said you have to call the Department of Health.
Right.
And so I called the Department of Health and I talked to the epidemiologist, who was very nice, called me back after 5 o'clock. And it turns out that Juarez is not an area that you have to worry about Zika virus. So
Exactly.
it's kind of
Yeah.
FYI, but it was
The
really
state
helpful.
of Chihuahua now is currently not considered, but I guess it was a great exercise for you to
It
try to
was.
try to figure out all the permutations of this.
Yes, exactly.
What is the turnaround time for the testing? How long does it take?
It's a while, and you bring up. Thank you for bringing that up. I think our experience has been like 3 to 4 weeks before you start getting testing back, and then of course, if they were exposed and IgM negative, and you saw them within 2 to 12 weeks, then they're telling you to get IgM again. You could be 34, 35 weeks before you're getting things back. What's impressed me just going through this, however, is, and I think frankly it's probably because of the HIV crisis, it seems like our system is really geared to respond to all of the challenges of this really quickly. When you think about initial CDC recommendations came out in January, and here you've got a phase 1 trial of a vaccine in August. That's great. And so all of the laboratory testing and vaccination, I think this can happen quickly, but I will say that I read something, just a quote from, I think it was the director of the National Institute of Health, who said, I feel like we're fighting this with one arm behind our backs right now because we don't have the funding. And to hold something up, hold research up and treatments up for something like this is deplorable. It is. It's just deplorable.
Okay.
Thank you, Gary.